volume data set. So okay, now running through, scrolling down from craniocaudal direction, try to pick all the signs that you need for your interpretation and diagnosis. Now I'll just show the coronal ones to be able to judge the gradient and other stuff, and also sagittal ones. Now if I have to just stop at the representative images, this would be it. So what we can do is, this is not going to be just a didactic talk. So I don't think it's feasible for somebody to turn off their mic and speak about it. So what we can do is, you can type in the chat box, what do you think about this. The one thing that is required is the pattern. You may not be able to see the pinpoint diagnosis, but what is the pattern of interstitial lung disease, you can type in chat box, not in the Q&A. Let's reserve the Q&A for the questions only, which I'll take at the end of the talk. So in chat box, yes, so number of people have said, so your UIP pattern, as you are mentioning the pattern correctly, but even if you want to say the particular diagnosis also, as and when you are confident to say so, you are most welcome to do that also. So yes, as most of you said, UIP pattern. So I hope everybody is already aware about the classification of UIP and the definition. So remember, UIP is a pattern. So initial days in your residency, you might be confused with UIP being a diagnosis. UIP is just a pattern, not a diagnosis. So UIP pattern has also three subtypes, which is a typical, probable, or indeterminate. And the fourth bucket in the classification is actually a non-IPF diagnosis, where you know for sure that this is not a UIP pattern. So those are your three UIP patterns, and each have their own definition. So typical UIP pattern, for anything to be called as a typical UIP pattern, you need to have four criteria fulfilled, and that we will discuss after this case. So what do we see here is, we can clearly see there is a reticular opacities with peripheral and subpleural distribution, right? You don't see anything in the bronchocentric distribution. So it's peripheral, subpleural, and you can make out there is a basal predominance, and for which you can take help of sagittal or coronal also. Sagittal are best to show this gradient. You can see this is the involvement of upper lobes, while this is the involvement in the lower lobe. So there is a definite apicobasal gradient. And can you appreciate the honeycombing at the lung bases, right? Right more than left. So that's your honeycombing. Again, the definition of honeycombing is the clustered cysts which are stacked one upon the other with shared walls. So that's what the honeycombing is. Of course, there are mimics, and we have discussed those also in the talks. But typically with this volume scan, most of the mimics also do not come into picture. Like, you cannot be mistaken in this for bronchiectasis, because those used to be in the days of films where they used to see all this on film. But now we can trace up and down, see whether they are contiguous with the bronchus or not, and we can come to know that this is nothing but honeycombing. So we have a basal predominant honeycombing also. Then do you have the other signs like ground glass, nodules, cystic lesions? And for air trapping, of course, we need expiratory scan, but just looking at this, there is no mosaic also. So all these other parameters are absent. Remember, this is also equally important. The presence of this subpleural reticular basal reticular opacity to honeycombing with traction market is of course in this case, but the absence of other findings is also important. That tells you that this is not just a UIP pattern, but a typical UIP pattern. Now, I told you this is a 72 years female, right? So what is the importance of calling anything not just a UIP pattern, a typical UIP pattern is, on HRCT alone, we can make the diagnosis of idiopathic pulmonary fibrosis. Remember, now I'm using the word diagnosis. UIP is a pattern, while IPF is a diagnosis. Only when you have a typical UIP pattern on CT scan without any underlying etiology, then only based on the CT alone, the diagnosis of IPF, idiopathic pulmonary fibrosis, can be made. And for this cases, if there is a good clinical concordance, there will be no biopsy required to confirm this diagnosis. As against if this is same pattern, but the patient is already a known case of, say, connective tissue disease like rheumatoid arthritis, then we cannot call this IPF, right? Because this is not idiopathic any longer. There is not absence of underlying etiology. There is underlying etiology, which is rheumatoid arthritis. So then this becomes rheumatoid arthritis or RA-related ILD with a UIP pattern. So I hope this distinction is clear. What is UIP and what is IPF? So that is the importance of this case, and of course, then you will have to look for any superadded complication or other thing also. So now, having understood this part of UIP, let's try to look at this case. So now this is a 56 years old male who presented with 6 months of dyspnea and cough. Now what do we see here? I am scrolling the axial section in a craniocaudal direction. Again going up. just to quickly show you the coronal and the sagittal, right? So what we discussed about the previous case, typical UIP pattern, is this looking the same? There is subpleural reticular opacities with basal predominance, right? There is a clear apicobasal gradient also. There is honeycombing, there is traction bronchiectasis, and there is absence of ground glass, nodules, cystic lesions, and even air trapping. So, or as long as the descriptors go, everything is just like a previous case. So are we again going to call this IPF? The answer is no. So again, even if there is no history available of any known case of being rheumatoid arthritis or etc., there are certain findings of UIP pattern on this scan which suggest on CT scan alone that this patient might not be having IPF, but rather a CTD or a connective tissue disease related ILD. So that's the importance of some of these signs, that without having any definite diagnosis labeled to the patient or available to you, you yourself should think of a CTD related ILD for this UIP pattern rather than IPF. And there are a number of signs which are present in this scan itself. So as you can appreciate as against the previous scan, now you see a very significant involvement of this anterior part of the upper lobes, right? They are not mildly involved like the previous scan. Of course, there is still basal predominance, but the upper lobes anterior part are very significantly involved, not mildly involved like the previous scan. So that is your anterior upper lobe sign. When you see this part of the lungs, that is the non-dependent upper lobes or the anterior upper lobes, if they are very significantly like this, there are not just reticulopathy, there are extensive honeycombing also, then you call this anterior upper lobe sign. Then what about this lower lobes? We see extensive honeycombing, right? And doesn't it look like a very extra large in quantity as against the previous scan? So that is what we called as a exuberant honeycombing sign. As against the previous scan where there was just a basal mild honeycombing, not involving significant amount of lower lobe volume. This year, you pretty much feel like this is involving more than 50%, maybe even in lower lobe, even up to 70%. So, by definition, if any lobe shows honeycombing which is involving more than 70% of its volume, that's the exuberant honeycombing. But even visually, say for example, in right lung, if you don't feel this is 70%, but still it looks quite a lot, right? Because the basal segments are almost entirely involved by honeycombing, that is still your exuberant honeycombing. So these two signs are present in this case, which tells you that this is not just a UIP of IPF, but this is likely to be CT related UIP. And many a time these patients are not diagnosed, like in this case itself. And then when you put down on your paper that these signs are present suggestive of CT related ILD, then the further workup will be done and the diagnosis of one or the other CTD may be proven, and that's how the diagnosis will be confirmed, and ultimately this patient will be then labeled as those that particular CT related ILD with a UIP pattern. So I hope this distinction is clear. And apart from that, can anybody appreciate any complication like thing here? So I'm stopping at that particular slice where you see some complication. So what is the complication that we see here? Pulmonary hypertension, not really. Even you can appreciate, but we have to measure also. So yes, so there is a pneumomediastinum. So again, the whole point is whenever you are looking at the scan, don't forget to actively look for any complication, which can be like now what you have mentioned is one is pulmonary hypertension, for which we'll simply measure the MPA. If it is more than 29.5, then we will call this pulmonary hypertension. We can even take the ratio of PA to AA ratio. If the pulmonary artery is larger than aorta, then also you can suggest. Again, that has to be confirmed with echocardiography, but something that you can see on CT scan. Then other is acute exacerbation. I'll see if I have a case, then I'll show the. So, like I said in the UIP definition, there is no space for ground glass. But many a times you will see a definite UIP pattern like this, and there are still patchy ground glass that can be still be present with UIP pattern, and that doesn't go against the diagnosis of UIP pattern, and that are actually related to acute exacerbation, which can be due to infection also, but sometimes even just acute exacerbation or the flare up of the ILD itself. For in those cases, you will see such patchy ground glass areas superimposed on this background fibrosing ILD. And remember, there will be clinical also concordance with it. If you ask the history, the patient will say that there has been acute exacerbation. He may be symptomatic with cough or fever for longer duration, maybe years, but suddenly in last few weeks or days, he has started developing more worsening of the symptoms. That way, it will correlate also that the acute exacerbation, that ground glass is due to acute exacerbation. Then, of course, tuberculosis and even carcinoma, lung cancer. The patients with ILD, fibrosing ILD, particularly like UIP, are at a higher risk for malignancy, lung malignancy than the rest of the population. So always make sure you look for those complications. And like this case, pneumomediastinum, which can be due to rupture of one of these mediastinal cysts. You can also have pneumothorax also, which can occur in cystic lung disease or even in honeycombing. So that's the importance of this. And again, after one more case, we will go to some theory part of UIP and CT related ILD. So I'll want to show you one more case also which goes with this, and then we can proceed with that. So this is the next case. This is a this is a 52 years female who presented with again 1 year history of progressive dyspnea. So again, I'm going to scroll in the craniocaudal direction once, and then coming back up again, coronal and sagittal. So what do we see here? Now again you see subpleural reticular opacities with basal predominance, right? There is a basal predominance here, but we do not see honeycombing, right? We do not see honeycombing, but we see traction bronchiectasis, and we see some patchy ground glass also. Can you appreciate all this ground glass which is along with the reticulation and little bit showing bronchocentric distribution? So this is your findings that are present. So now again there are ground glass present, which I said in the previously, it should not be present in a UIP pattern. And plus, if can you appreciate a homogeneity here? Though there is a gradient, I agree that there are bases more involved, but still there is a homogeneity in the sense that the appearance or the morphology of the lesions at the upper lobes and the lower lobes are same. So that's what we mean by temporal homogeneity when the lesions are showing same stage. So earlier case, if you remember the first case, the upper lobes were showing mild reticular opacities, while the lower lobes were showing not reticular opacities along with honeycombing. So that's not a homogeneous appearance. This is the temporal homogeneous appearance where the lesions looks almost the same at the apex or the upper lobes as well as the bases. But there is no spatial homogeneity. So there is still a gradient present. Many a times you will see a spatial homogeneity also where the upper lobes will also be equally involved. When you see such homogeneity and sometimes even subpleural sparing, which is not present in this case, this tells you this is a NSIP pattern or a non-specific interstitial pneumonia pattern. This is not a UIP pattern because number of factors of the definition are not fulfilled. And can anybody pinpoint this diagnosis? This can even come as a spotter in exam. Yeah, many of you have already said scleroderma because we see this dilated esophagus. So remember NSIP, though it's one of the idiopathic interstitial pneumonia, IIP, right? After UIP comes NSIP. Typically, we do not label any NSIP pattern in idiopathic scenario. So either the patient will already have a known etiology or will be eventually found, but CTD related ILD are the commonest cause or sometimes drug related for NSIP. And typically these patients are relatively younger than the UIP pattern. So less than 60 years with any underlying etiology, then those are likely to be NSIP. Older than more than 60 or definitely more than 70 and without any underlying etiology, those will be your UIP pattern. But the two important characteristics to look for in NSIP, not necessarily always present. The first is subpleural sparing, but the moment you see subpleural sparing, so that sign has a high specificity and low sensitivity. The moment you see it, it is going to be NSIP and definitely not UIP because UIP process starts in the subpleural region, so you cannot have any sparing there. But if you see that, then that tells you this is NSIP. But it doesn't mean that all NSIP has to show it. Like in this case also we don't see it, but this is NSIP related to scleroderma. And second is temporal and spatial homogeneity, apart from the usual fibrosing ILD signs that we discussed. So now with this background, I think we can see some of the theory part which will help understand what I have described and with the help of these three cases. So is my PPT visible now? And somebody just mention in chat box as yes, because I've kept my screen sharing on. So whatever comes on my screen should be there. Yes. Okay. So this is what we are going to discuss now. Typically, you have a pattern. Like I said, all these four part of the definition has to be fulfilled. Reticular abnormalities, honeycombing. Remember, traction bronchitis is not must with or without, but typically when you have honeycombing, that advanced stage of fibrosis, you will see some degree of traction bronchitis. But as long as the definition goes, it is optional. Subpleural basal predominance and absence of other findings. All these four has to be fulfilled to call anything as a typical UIP pattern. And like I said, the importance is if there is no underlying etiology and good clinical concordance, then we can label directly on IPF without any need for biopsy. These are the mimics that we usually discuss, but not of importance right now. And then what if there is no honeycombing? So the other pattern of UIP, this example, if you see all the other criteria, the basal subpleural predominant reticular opacity is again there is traction market traces, there is basal subpleural predominance, as you can see the gradient here, and absence of other findings. But only one thing that you don't see is the honeycombing. Honeycombing is absent. Rest everything is fulfilled. Then this is still a UIP pattern, but a probable UIP pattern because all the four are not fulfilled. And the importance is now to call anything directly IPF based on the CT scan alone, that power is lost. So typically these cases progress to the multidisciplinary discussion, and if there is still a good clinical radiological concordance, the clinically also they are suspecting IPF, then the diagnosis will be made. But if there is a discordance, then many a times this patient will require a lung biopsy for definitive confirmation. So that's the importance of this. Then last bucket is consistent with non-IPF diagnosis. So as against the basal predominance, if you see upper zone predominance, as against the subpleural distribution, you see central or peribronchovascular distribution. And instead of absence of these findings like ground glass nodules, cyst, thread wrapping, if they are present and in a good proportion, then all these are clearly opposite to what we expect in typical UIP. So naturally, this is non-IPF consistent with non-IPF diagnosis because now you are pretty much sure that this is not going to be IPF. And most of these cases are due to chronic HP or sarcoid that we will discuss in the forthcoming session. So this is what we talked about so far, the UIP pattern, typical, probable. There is something called as indeterminate also where you still after careful analysis, you cannot put that in one of the remaining three buckets. There is a variable or diffuse involvement and some inconspicuous features, then you can label something as an indeterminate also, but typically we try to divide in one of these three buckets. Now let's talk briefly about city-rated ILD. So initially this paper came by Chung et al. In 2018 where they described three signs. The one sign, the couple of signs that we already saw in the case are the anterior upper lobe sign, right, where there is a significant anterior part of the upper lobe involvement. Next is the exuberant honeycombing, like I showed again, typically more than 70%, but even if you see exuberance, it's good enough. And the straight edge sign, which is rather, I would say, the most important sign. So many times we just put any fibrosing ILD in the MPR reconstruction just to see this sign on coronal or sagittal. So if you see the example, and like I said, why you need the volume data scan, because this sign is not seen on your axial scan. For this, you need to have a volume data thin section so that you can have this good reconstruction in coronal and sagittal, where you appreciate this straight edge which is separating this fibrosis from this normal lung, right? Both on the coronal and sagittal. That's your straight edge sign. And just to show the contrast, this is the IPF where you cannot make draw such one straight line. It is going somewhere here, then here, again here. It's something like this. But here you can make draw very straight edge like this between the two, and that's your straight edge sign. So these were the three signs initially described in this paper, and after that a lot of work was done, and some other signs also came up. The first was four corners sign, and this was specifically described with scleroderma related ILD, where there you have a specific involvement of the four corners of the lungs. That is, this part, the upper lobes anterior part, and the lower lobes posterior part. On both the sides, that collectively makes the four corners of involvement. So you might think that the lower lobe posterior part is what we see in UIP also. So how it is different? Remember, this is not at the bases. If you see the sagittal recon, the bases are actually not significantly involved or spared. Rather, it is somewhere higher up. So that is what it is little different on coronal. Also, you can make out that there is not at the base itself. Those four corners, if they are preferentially involved, like in this case, this is CT related ILD and more so, more specifically a scleroderma related ILD. Then just a couple of years back in 2021, this also paper came with described number of additional signs, particularly more commonly seen in SLE, systemic lupus erythematous, and they showed said this heterogeneous lung destruction. Whereas you can see in this example, you have honeycombing, plus you see some this large cystic destruction in the lungs, plus you see some low attenuation area like this, which do not appear to be like honeycombing, they are not at the bases. So such type of heterogeneous destruction, if you see, then that also suggests a CTD ILD rather than IPF. And like I said, these are more common seen with SLE than any other CTD. Then island-like fibrosis. So if you see this example, there are just few patchy areas of involvement in this slice, and they look like a small island of involvement, which a sharp demarcation with the normal lung, and then the rest of the lungs adjacent is spared. Where you see such specific small island-like areas of fibrosis, then that is also sign for CTD-ILD. Then many a times you see such low attenuation areas without any definite wall. So they don't look like honeycombing clearly. They don't even look like a cyst, but just a low attenuation area within the areas of fibrosis that also is a sign of CT-related ILD. So number of paper also retrospectively try to see how good these signs are. And what they found is while the sensitivity is pretty low, so meaning that not every CTD ILD is going to show this sign, but the specificity is very good, over 90% for most of the signs. So the if the signs are present, you are more likely to be right to call this as a CTD ILD, and this will turn out to be CTD ILD than not. And this is what I described in red bars also. You can refer to that. So with this, now we can okay, just to brief about NSIP also, I think that we have already discussed. Just the subpleural sparing, like what I was telling is, if you see this subpleural sparing, sometimes it might be difficult to pick up on axial, then do this again sagittal recon. You can make out this straight entire area of lung which is paired. And again, once you have a subpleural sparing, that is definitely not VIP but NSIP. So a 35-year female with arrhythmia, and can anybody think of a particular diagnosis, not just NSIP? We already know, so, but what about any specific diagnosis based on the history? So yeah, amiodarone. So remember, drug-related ILD, like I said, after CTD, drugs are another common cause for NSIP pattern. And for that, you need to really ask the patient in detail because they might not feel it is important to describe or mention about the history of arrhythmia in case of lungs, lung scan being done. So therefore, the importance is that it is of great importance because the moment you make this diagnosis, the patient will be then asked to stop this drug. And typically, if that is the case, then they usually show a good improvement. So this is the 2 months follow-up after stopping amiodarone. You can see the lesions are already regressing. So now we can start again looking at the other cases. So this was basically about the UIP pattern and the CT-related ILD and the NSIP pattern. Now we can talk a little bit about the other ILDs also. So again, I hope the scan is now visible in my Osiris viewer in 3D, right? Okay, can you see just one time? Can anybody say yes? Then I know that this is switching properly. Okay, good. Thank you. So let's see this case. So this is a 39 years female with 3 months of dyspnea and cough. So patient also had previous scans also, but now she was again symptomatic for 3 months and came to us for a follow-up after good 5 years of the first scan. So scanning in craniocaudal direction, in axial again going up. Now just to show coronal also and sagittal also. So what do you think of this? If I stop here. What do you think of this? Okay. Somebody says just ILD. Okay, yeah, all cases are going to be ILD. Okay, city related ILD, right? Because anterior upper lobe sign, that's what you think? Okay. So first of all, remember, again you see honeycombing. So many times what I've seen is the moment you see honeycombing, your thinking stops at UIP pattern only. So like I have already showed that honeycombing can occur in a UIP like pattern of CTD also, which is not IPF. And also these are a couple of more examples to say that UIP is not the only place where you see honeycombing. So now let's analyze this scan. We see reticular opacities with honeycombing, but what is the distribution? Is it peripheral, subpleural only, or there is a significant bronchocentric involvement also? Yes, if you see this upper lobes, there is significant bronchocentric involvement. You can even see on coronal along the bronchovascular bundle. And is there a basal predominance? The answer is no. You can see on sagittal also, the upper lobes are more involved than the lower lobes. In fact, the honeycombing is seen only in the upper lobes, maybe a little bit in the lower lobes in the ear, but nothing at the base is significant. So the distribution is completely opposite. You see a bronchocentric distribution and you see a upper lobe distribution of the reticular opacity and honeycombing, and plus you see significant ground glass, right? It is almost diffuse ground glass involvement. And can you appreciate the interstitial nodules? I think in upper lobes here you can easily appreciate at on both the lungs, and even as you go, so practically almost everywhere they are present, but these are the areas where you see more commonly here also. So you see nodules also. So again, what do you call this pattern as long as the classification goes? Where you will put this in which the bucket? Can you call this typical UIP? No, because we already discussed the distribution and everything is different. Plus, you see significant other signs also like ground glass, etc. You can't even call probable UIP again. There is honeycombing. You don't think this is indeterminate. So this is rather the final bucket which we just discussed, where we see upper lobe predominant bronchocentric fibrosis, honeycombing, plus ground glass nodules. So this is your non-IPF diagnosis, and typically, like I said, these are the cases of chronic HP or sarcoid. Based on this, then further the nodules, if they are present, that will help you. So here we clearly see bronchocentric nodules. With, if you can appreciate this lobular air trapping also, you can do expiratory also to confirm this. This, can you appreciate this lobule-like areas of air trapping? That's your lobular air trapping. That tells you that this is a case of chronic fibrotic hypersensitivity pneumonitis with non-fibrotic component as well. So that's how you make this pinpoint diagnosis. Remember, now we do not use the earlier terms for hypersensitive pneumonitis like acute or chronic or inflammatory, etc. We just use the terms fibrotic or non-fibrotic, and like in this case, you can even have both coexisting. So here we will call this a chronic HP with both fibrotic and non-fibrotic component. The non-fibrotic component, that's the ground glass with nodules, can be even acute exacerbation or a part of chronic process for which you need a previous scan. Suppose this is imaging appearance of ground glass and nodules is unchanged since last 1 year, then I know that this is not a part of acute component. This is rather a chronic component only. In as against if you have the patient who has a previous scan with fibrosis only and now he presents with acute exacerbation like symptoms, and you see this new nodules and ground glass, then you know that these are a part of acute exacerbation or a acute component of the non-fibrotic. But as long as the diagnosis goes, they are interested in knowing only whether the fibrosing or non-fibrotic form of HP is present. So this is the typical example for this. Then we can even look at the number of these cases also. These are very typical ones. So first we'll take a look at the lung window only. For this type of cases, the history is not important actually, so I'll skip it. What do we appreciate here? First of all, do you see any reticular opacities or honeycombing or traction marketosis or architectural distortion? No, right? So this is a non-fibrosing ILD. So remember, anytime you report ILD, your first line, even if you are not confident of diagnosis, not confident of a pattern, at least be confident to call whether there is a fibrosing ILD or non-fibrosing ILD. Then also the half the job is done. The clinician at least know that this is a fibrosing or not, and accordingly he can also make a lot of judgment call based on that information alone. So all the previous scans showed the size of fibrosing ILD, which are reticular opacities, honeycombing, traction bronchiectasis, and architectural distortion. This case shows none of them. So this is a non-fibrosing IID. Plus, can you now clearly appreciate nodules, right? I will just zoom into this right lung only. So what is the distribution of the nodules? Can you appreciate those along the vessels, right? These small vessels are showing this nodularity. Even on coronal, you can sometimes appreciate better like this vessel. This is showing a nodular appearance. Plus, what is this? This is your fissure. Again, the fissure also shows that there are nodules along the fissure. You can use this sagittal and coronal recon here also to clearly demonstrate this fissure nodules. See, you can see number of them along the fissures on both the sides, not just right but also on the left also, though more severely involved on the right side, but here also you see along the fissure on the left also, and plus some subpleural nodules. So what is this distribution as against the previous HP example where we saw bronchocentric? This is showing perivascular, subpleural and fissural, where the lymphatics run in secondary pulmonary lobule. So this is your second perilymphatic distribution. And if you can even appreciate, the predominant distribution is also perihilar rather than the upper apical or a basal predominance. So that's your typical for sarcoidosis. Any perilymphatic nodule disease, the typical example is the sarcoidosis. And then of course you will want to see plain also, and this is one of the time where you will do contrast also, because on plain, once you see that there are lymph nodes, it is a good idea to see whether there is necrosis or not, because remember in sarcoid also you can still have tuberculosis. So we have seen many examples with this typical sarcoid appearance. The plain scan showed lymph nodes, nobody then did contrast, and they were actually showing necrosis, and patient also had tuberculosis. So that's why it is very important. So remember, it works both ways. It's the first tool is no diffuse lung disease should have contrast then unless there is indication. So most of the time you can make your entire interpretation diagnosis just on the plain scan. But the only time, that is when you see lymph nodes like this, or you have a superimposed complication in the lung, like say mask or other complication, then only you give contrast. To diagnose or evaluate the interstitial lung disease itself, you don't need contrast. But the moment you see this, you do contrast, you can see non-necrotic typical mediastinal and bilateral hilar lymph nodes. So this is stage 2 sarcoidosis. And for this, again, try to analyze the nodules, because once you have a non-necrotic lymph nodes, it doesn't help you to differentiate between tuberculosis and sarcoidosis. The only way is to based on the lung lesions. And many times, if you are still confused with calling this tree in bird or bronchocentric, you will make a wrong diagnosis of tuberculosis. So this perilymphatic distribution is also not so difficult. The moment you see few of the cases, you should be able to then make this diagnosis accurately. Then I have one more example for advanced sarcoid also, because every time it's not so simple also. Yeah. So this example, what do you think? So this is reticular opacities. Again, if you appreciate, there is a significant bronchocentric involvement. It's not only subpleural. And now can you appreciate this is a homogeneous appearance or a without any gradient, right? You see sagittal, you see coronal, you even go from axial. The upper lower lobes appears to be almost equally involved. So these are all your signs going against the typical UIP pattern. Now you are left with non-IPF. Now to differentiate whether this is chronic HP or chronic sarcoid is actually difficult unless you see typical nodules, either bronchocentric nodules of HP or perilymphatic nodules of sarcoid. And many a times, like in this case also, you don't see either, then you can still leave it that this is a fibrosing ILD with consistent with non-IPF diagnosis. It can be either HP or sarcoid, and then further clinical workup will be done to differentiate the two. And many times they will also go ahead and do some form of biopsy for histopathological confirmation. But as long as the radiology is concerned, it's okay to stop there, because not all the time you can differentiate the two. But many times, as in this case, you can have some other signs like this. What do we see here? I think, yeah, I have a soft tissue also. You can see, just see the thick sections here. Yeah. So what do we see here? The lymph nodes are present with this typical, what is this pattern of calcification? Eggshell, right? You see at the periphery of the nodes looking like an eggshell. So this type of additional information, if you also have, or you have a previous scans before this fibrosing stage develop, if the patient can pull out a scan 3 or 5 or 10 years back at the time where there was no fibrosis, you can again see the nodules and make this diagnosis. So look for this additional sign, but even if you are not able to, then at least telling this is a not a IPF, but one of these two, that is also a job that is half done. Okay, so now we can then move to some of the other cases quickly. I think we have time, so can just quickly look at this type of cases also. Again, now we are switching to non-fibrosing ILDs. Right. So I'll go a little quicker because here we don't have too many signs. We have just one finding to be looked at. So this is what. Do you see any sign of fibrosing ILD, reticular opacity, honeycombing, tracheomacritis, or architectural distortion? Again, the answer is no. Please don't get confused with some of this post-infectious inflammatory fibrosis. So the predominant pattern is this lung cyst, right? So what do we call this? Is the cystic lung disease. Remember, don't call cystic ILD. Not all this cyst lung disease, like in fact this example itself, are ILDs per se. So the best term used when you see cyst as a dominant component in your diffuse lung disease, to call it as a cystic lung disease. Though in HP, example like HP ILD, where you can see cyst, those cysts are actually ILD, but these are the example where it is not a ILD but rather a cystic lung disease. So use the term correctly. Now, what do we do further once we see cyst? First, we take a note that this patient is a female, right? Then what about the cyst? Cysts are showing basal predominance. Plus, there is, if you can see, there is a costophrenic angle involvement also. And most of the cysts show this homogeneous round shape with perivascular distribution. So this in a middle-aged female. This patient is a 42 years female. So then it fits for a diagnosis of So far, still okay. I have a couple of correct diagnoses, but incorrect also. LCH also somebody saying yes, LAM, lymphangioleiomyomatosis. So this is how you can make this diagnosis in a typical clinical scenario with this typical appearance. And remember, the intervening lung is normal. So that's why this is not an interstitial lung disease where the interstitial is not involved. So that's why you don't see any ground glass or reticular opacities. You just see a plain and simple cystic lung disease, and that's what the LAM is. And one more clinical parameter that can help you for this diagnosis is when you do a vascular endothelial growth factor level. Those levels will be sky high. In the patient with LAMP, the blood workup will also help to confirm this diagnosis. Then this is example of other type of, now we are looking at the some of the cystic lung diseases. Now what do we see here? So again, first note this patient is a female, right? Plus you see some cysts, some nodules. Now is the intervening lung parenchyma normal? No, you see this nodules and branching type lesions also, and some glass. But see some cysts which are showing like this thin walled, some cyst which looks thick walled also, and then you see that the costophrenic angles are actually spared. So this, though this patient is a female, so remember this diagnosis, you stop thinking about it the moment you see a female, and it's not true. So yes, somebody now correctly asked for a history of smoking. That is more important than the gender. So you can have a female smoker also like what? Typical distribution and morphology of Langerhans cell or a pulmonary Langerhans cell histiocytosis. So remember right to write the whole term correctly. It's a PLCL because this is a pulmonary Langerhans cell histiocytosis where you see such nodules and cysts in a different stage of evaluation, all coexisting, even in the same lung, same lobe also, because this is how it typically evolves. So it starts from nodules, then it starts cavitating, then it shows thick walled cyst first, and eventually thin walled cyst. All can this temporal heterogeneity can all be existing in the same patient, same lung, even the same lobe. So that's how you make this diagnosis. And for this, smoking is more important rather than gender because this is more commonly seen in smoker. So that's why even if you have a female, stop thinking of the diagnosis and always ask for a smoking history even in the females. And then we have one more example of this type of, since we are covering the cystic lung diseases, let's see this example also. So now what do we have? Again, we have a female patient. So this is good. We have all the female patients just to tell you that not every female with cystic lung disease is LAM. So this again, what do we see here? We see cyst. Almost looks like the first scan, right? So first thinking, if you are even thinking first L for LAM, it's not going to be completely wrong. But here again, notice the intervened lung parenchyma is not normal. There are patchy ground glass area. Here it is best seen. Here this is ground glass. There was a bit of in the right lower lobe also. So this is what the spared, the interstitium or the intervening lung parenchyma is not spared. You can see even in the right lower lobe this area of ground glass, and there can be more also. This is the time you should stop thinking of LAM and think of LIP or a lymphocytic interstitial pneumonia. Again, it is one of the idiopathic interstitial pneumonia IIP, but just like NSIP, you see typically in this in case of Sjogren's syndrome or even rheumatoid arthritis or immunocompromised state, etc. But typically, the diagnosis is hence made only when you have these underlying conditions. In a idiopathic form, to make this diagnosis will be a little difficult. But most of the time, when you ask for the history in detail, you will come to know that this patient has some of the other of these above previously mentioned conditions, and that's how you can confirm your diagnosis. But remember to differentiate from LAMP, this lung intervenous lung parenchyma is not normal. There will be some ground glass typically like this, and typically then you ask for this underlying conditions also. And just to complete the spectrum, I think I should show this also. Yes. So this again, now notice this is a cystic lung disease. Now you have that complication which can happen with any cystic lung disease, which is a pneumothorax, because any of this cyst can rupture anytime, and it is not specific to this condition or any of the which described previously. Any cystic lung disease can have a pneumothorax. But now notice the difference in the shape. It is not rounded like we saw in the previous example. Here you now started looking at bizarre shapes, like this is a lenticular, this is somewhat triangular or a clover leaf. This is also a lobulated cyst. Here also again you see septated cyst. This type of heterogeneous in morphology, then you start thinking first of Burtock-Dubé syndrome. So this again patient can be male or a female, but typically this type of a morphologically heterogeneous cyst with different shapes and even septation many a times, like in this example you see in the left lower lobe, then you start thinking of Burtock-Dubé or a BHD syndrome. Typically, they will show this perivascular and subcutaneous distribution with lower lobe predominance. And in this cases, always pay attention to the kidneys also, whatever you have covered, because these patients are also at a high risk for associated renal malignancy. And typically, the diagnosis is made clinically by looking at a skin lesion, what are described as fibrofolliculomas. And final confirmative diagnosis, of course, genetic, because this is a genetic disorder where there is a fibrofolliculin or a FLCN gene mutation. So once you raise this possibility, the further genetic workup will be done to know whether this gene is mutated or not, and that's how the diagnosis is confirmed. But remember, this is a rare, but not something that you won't get at all. So that's why keep this diagnosis in mind. And whenever it is not fitting in one of the common previous ones that we discussed, the LAM, LCH, LIP, then always give this possibility because then only the genetic workup will be done and this diagnosis can be made. So I think with that we have covered most of the part that we wanted to see. And just to show one example of this also. Sorry, here you can see the details. Okay. So what do we think of this? So this is again fibrosing or non-fibrosing? Okay, so people are calling fibrosing because this looks like fibrosis. This is actually not fibrosis per se. Remember, these are bronchocentric mass-like lesions, and we will discuss in some time before we make the diagnosis. I mean, first we make the diagnosis. So, what do we think? See the rest of the lungs. There you don't see anything else. You see again a nodular lung disease. The one, for example, that we saw earlier are the HP and the sarcoid. So, what do you think this distribution? So again, this looks like a little bit of a random distribution, but notice how the nodules are. They look very dense than the previous example where they were kind of ill-defined or not so dense. So this is one such time where you will think of one particular condition, and again you need some history also that will come to that, and then you know also that what this can be. So many times these are mislabeled as either superadded infection like pneumonia, where they label consolidation, or many times you can even label this as a masses and ask for biopsy to rule out malignancy. But this is nothing but this patient. Then once you see this type of high density randomly distributed nodules with even lymph nodes like this, some of them may show axial also, then you ask the patient for silica exposure history. Yes, now many of you have started getting the diagnosis right. And once you have the silica exposure confirmed, then you label this as a silicosis, and these are nothing but part of progressive massive fibrosis. So remember, anytime you see randomly distributed nodule with high density, and always in general also keep a habit to ask any CTD, smoking history, or even exposure history and occupation history for every patient. But at least even if you don't have, when you see this type of findings, always ask for that. So this is what this is just to show as a differential for sarcoid. Many times these are also labeled as sarcoid, but remember this is nothing but silicosis. And finally, just to show the importance of a follow-up scans. So every time, like I said, once you have made a diagnosis, even on follow-up, just you should not pay attention just to see whether there's a progression or regression, etc. You should always pay attention to the superadded complications. So what is this? I'm showing here. So if you have attended my previous lecture on infection, then you will label this correctly. So many are saying aspergilloma, fungal ball. So again, terminology. What would be the right terminology? If I tell you this patient is symptomatic for 3 months, actually this is what we'll call as a chronic cavitated pulmonary aspergillosis or CCPA, right? So again, everybody got this right that this is a fungal ball, but again, get the terminology also right. A fungal ball or a simple aspergilloma is when The patient is not symptomatic for this, and this is not progressive. Once they have symptom for this, it is CCPA, and they will also be showing typically progression also. So that's why I always look at all the fibrosing ILD or any ILD cases for such complication also. So I think with that we have about 50 minutes of what we have discussed of the cases. I think last few minutes we can also have for Q&A also. I have tried to show you most of the typical ILD cases that we see, common cases that we see in practice and also comes in the exam. The typical fibrosing ILDs like UIP, where we also discuss about CTD, then NSIP. Cryptogenic organism pneumonia I didn't show because it's very simple, bronchocentric and atrial sign, etc. And then we also looked at the nodular ILD, HP, sarcoid, and finally some cystic lung disease. So I think there are a bunch of questions already in Q&A, so I'll take that first. Sir, kindly explain apical-basal gradient. So apical-basal gradient is, again, if you see on Excel also, you can appreciate as you go here, if the upper lobes are showing very mild involvement and suddenly as you go down, you see significant involvement, that's your apical-basal gradient, right? Where the bases are involved more than the apex typically, or even the apex can be involved more than the bases. But and even if you're confused on eggshell, you can always put sagittal. Like in this example, you see the upper lobes are involved more than the lower lobes, right? So this will be upper lobe predominant gradient. So sagittal recon will help you in that also. But that's about it. And typically the gradient is seen in UIP pattern and not in NSIP. Next question is show the nodular air trapping. So it's not nodular, it's lobular air trapping. So if you know the shape of the secondary pulmonary lobe, in fact, this example also shows some of that. So again, first of all, to demonstrate air trapping, you need to have an expiratory scan, but I'm showing an inspiratory scan because we don't have the one right now. I think I have in this case, yes. In this case, we have expiratory scan. So see now how the gradient is exaggerated. So if you see what is a lobular pattern is where you have a lobule involvement of air trapping. So this is the area of air trapping which is actually showing a secondary pulmonary lobule distribution. These are all secondary pulmonary lobule which are showing air trapping. This is then called as a lobular pattern of air trapping, and that is very typical for hypersensitivity pneumonitis. Then can you share a structure reporting format for ILD? Yes, I have shared in other also. I think let me see if this dictation. Yes, I have the one. Okay, and this PPT that I already opened. So this is how what we do is typical structure reporting template where we document the medical history comparison or not pattern distribution, all these 7 parameters that we discussed. And also there are points like superimposed complications. So the importance of structure reporting on a template basis, you do not miss out on anything. On any particular day, even if you forget to actively see this, then you will see this template, and when you come to this point you will make a point note to look for any complication or measure the MPA so that you don't miss out on anything, even the remarks, the final diagnosis. And like I said, it start with fibrosing or a non-fibrosing ILD, then if fibrosing or UIP or a non-UIP pattern, and then further specific diagnosis like sarcoid, HP or CT related ILD if possible. Comparison is always given if there are previous scan, and the suggestion like whether you ask for follow-up or CTD workup, etc. then then what is the next? Yes. Do you do lung biopsy for ILD? If yes, how do you choose area in indeterminate cases? So now, first of all, the lung biopsy for ILD is not done by radiologist. It will be done by the pulmonologist. But the time that they will come to you for a help is to mark out the areas where they should be targeting to do the biopsy themselves. So those area you can mark them on the HRCT scan, and remember not to select the end stage disease like one with showing heterogeneous destruction with large cyst with honeycombing, etc. You try to avoid that area. You try to show significant involvement, but not with the end stage disease, and at least mark out 3 areas, typically 2 in the lower lobes and 1 in upper or a middle lobe. But that's how it will help them to target appropriate areas which are significantly involved and representative on HRCT so that the diagnostic yield of biopsy is high. In silicosis, kindly tend again not able to see the dense nodules. Okay, so silicosis case, I think that should be the last open already. Yes. So again, you need to have a couple of them for comparison also, maybe if it is difficult to pick up on this. But I think I have one more case also. So let me show another this time. See if you can appreciate in the another scan also. So now, yeah, let's appreciate on this. Can you make out these nodules are very discreet? Again, this is not a good quality scan. So remember, first of all, this is not something that we know. First of all, it is, I think, yeah, it is from soft tissue that I'm converting to lung window. But notice how the nodules are randomly distribution with high densities. And again, you have to ask the history clearly. This patient also had a silica exposure. Do you still prefer the term acute chronic? No, I already said it is only fibrotic or non-fibrotic or both, but not other terms. Experience with COVID-related ILD. So yeah, nothing now, but COVID-19 lung sequelae are of course present, and those patients typically show either some degree of improvement or they are unchanged, but none of them are worsening. So anytime you see COVID-related ILD, which was present, always ask for the previous scan because that will only help you confirm. Otherwise, you might make a mistake to call any new ILD, and then none of them show progression. So if you have a progression, then also think that this is not a COVID sequel. It is likely any underlying background ILD. How to differentiate from TB? Differentiate what? So I don't use after even nodules that TB should be a problem because TB is a focal confluent involvement, not diffuse symmetrical bilateral like this, and the branching pattern, etc., and other signs like necrotic nodes or effusion, etc. Please explain temporal and spatial homogeneity. So homogeneity, temporal homogeneity is when you have a same kind of lesions. The upper and lower lobe lesions are more or less similar in terms of reticular opacities, degree of traction bronchitis, whether honeycombing is present or not, ground glass or not, etc. It will not look different. The upper lobes will not show a mild involvement like just some mild reticular opacities with lower lobe showing extensive reticular opacities, honeycombing, etc. That's not homogeneous. And spatial homogeneity is where you have a upper and lower lobes involved in the same degree of involvement. So the mild versus severe doesn't exist. Kindly explain the same question. Then in cryptogenic organism pneumonia is pattern or diagnosis. So again, same like UIP to IPF, organizing pneumonia is a pattern, and cryptogenic organizing pneumonia is a diagnosis where you don't have any underlying etiology. So if you have an etiology, so typically the organizing pneumonia pattern occurs with CTD like dermatomyositis, polymyositis, then you call that particular city related ILD with a OP pattern. And if there is no etiology, then just like when UIP becomes IPF, the OP becomes COP. So do not use the word cryptogenic organism pneumonia for every case unless and until the etiology is ruled out. Is it normal to have some amount of air trapping? Yes, of course. In an elderly, you can always see some air trapping, so you need to be a little careful before you label anything as air trapping. Then, if patient with typical UIP pattern develops GG or consolidation due to infection or heart failure, how are we going to categorize? So again, that is not to categorize the ILD. This is now your superimposed complication. So that's what I said. That don't think that this is not fulfilling the definition because there is a GGO. GGO can be due to superadded complication which can occur in ILD patient just like any other. So that's why it is still a background UIP with a superadded complication showing GG or consolidation. And of course, once it is treated, that will go away, but the underlying CT ILD will still be present. Then Apollo predominant sign I already discussed. Silicosis we just described. CCPA we discussed. Then treen bud appearance. Then apart from TB, can it be something else? So treen bud is for inflammatory or infectious bronchiolitis, not for TB. The commonest in our country is TB, but even non-specific inflammatory bronchiolitis in airways disease patient or some other infection can also show treen bud. But in our country, the TB is the most common cause. Can CTD directly show Apollo predominance? Yes. So that's what I said. That not just that they can be significantly involved, it can be predominance also. So yes, the answer is yes. So that also helps you to rule out IPF in this type of examples. In what's your plan outline in cases which are not classified in either categories? So yes, and many a times on an occasion, even despite of aggressive evaluation, we are not able to label a particular pattern, then it is still okay to call this as a unclassifiable or indeterminate pattern. And typically the follow-up imaging will then be helpful. So even if the classical signs are not present currently, eventually that may develop and it help you make a particular diagnosis. But it is completely wrong to just force yourself to label something as a one particular category. If you are not confident, if you feel that there are not enough signs, do call this as a indeterminate or unclassifiable ILD, and the follow-up will hopefully give you the correct picture. Now, next question is, have you seen cases of catamenial pneumothorax? Okay, yes, there are a couple of cases, even proven ones. I think I have one example also, but it will take some time to load it. But yes, the history is very typical. First of all, the pneumothorax is recurrent and coincide with the menstrual cycle. So patient will our cases, the couple of that I have seen pulled out at least 10 or 12 X-rays or done in over a period of 2 3 years. Every month they get pneumothorax, then it is resolved or treated with tube drainage, etc. And they keep coming. And then suddenly somebody thinks of it. Then we do a contrast CT test. Of course, not every time you are able to pick those nodules because they can be even microscopic. But yes, we have one or two example where we could see enhancing nodules along the pleura. That were the case, and the catamenial pneumothorax was proven. And now I think we can take just one last question. Uh, can you explain interstitial lung abnormality? So yes, the interstitial lung abnormality is something that we did not touch upon. So number one thing is interstitial abnormality is when there is no clinical suspicion for ILD. So the case scan is not done to find out a ILD. You instead pick up reticular opacities or signs of ILD as not expected findings. So the patient are also not symptomatic for those findings per se. Even if they have symptom, it may be related to something else, and typically it occurs in elderly. So earlier also what we used to say something like a aging lung, where they are invariably seen many a times seen in elderly patient who do not have any clinical history for ILD or a suspicion for ILD, but you see those reticular opacities. Then what do you call it? Do you call them as an interstitial abnormality? And those are still to be followed up. So even if you label ILA, you have to ask for follow up after 1 to 2 years whenever there is a clinical need. And if there is progression, or if they can also change to a frank ILD also. So that's why label ILA and then ask for follow up. So I think with that we can conclude this session. We have answered most of the question. Yes. So thank you so much for your attention for full 1 hour that we discussed, and I hope this case-based session was helpful to you to understand the interstitial lung disease. And see you again next time. So with that, we can I think conclude this webinar. Thank you so much again.
Yeah, thank you, Parang, for that amazing and comprehensive review of interstitial lung disease. You, as always, did an awesome job, and patiently answering all those questions by yourself without including me was cherry on the cake.
Yes.
um, we hope to have you again on this platform, as people just love your webinars, and as you can see in the chat, there are such positive
Yeah.
responses coming in. There are close to 300 attendees from around 35 countries, and it's been just, I'm sure they're all enthralled with the knowledge of interstitial lung disease that you shared today.
Thank you. Thank you so much.
Thank you, Paransia.